You're live now, Ashley.
Good afternoon, everybody, and thank you for joining us in this, our final series of the Autumn-Winter P&A RCSI webinar programme. You are most welcome this afternoon. And again, sincere thanks to our colleagues, Catherine Clumavani and Anna Halligan in the RCSI. And it gives me great pleasure to welcome once again our colleagues and friends of Dr. Angela Kokeman and Dr. Sheila Wickham. Today's presentation is physical health screening for people with mental illness. What is it? How it can be? What is it? How it can help? How it can be implemented, and practical interventions. As you know, this is the third in a three-part series where both Dr. Kokeman and Dr. Wickham have, I suppose, tried to cover the breadth of matters and incidents in relation to physical illness, but also in relation to screening and the whole concepts of how our mental health and interactions all combine, really, I suppose, in this way. It has been an immense programme, and there has been huge interest and popularity in respect of this. It is our intention, actually, to put up the suite of videos over the December period for you to recap, share with your friends, refocus, I guess, and also for us to understand and feedback and understand how indeed you experienced the whole programme and indeed the whole webinar series. I'm going to pass you to my colleague Catherine Clumavani. Catherine, as you know, has along with Anya coordinated this whole programme with the P&A, and we are indeed very grateful for that. So thank you, Catherine.
Hello, everybody. There's 35 of you here today already, so welcome. Our last one before Christmas, and hopefully many of you will get a break. I know you'll have duty, some of you, but hopefully the rosters have been fallen, you know, that you're not on for the whole of the Christmas and New Year. So I'm just going to follow on from Aisling and give you a little bit of detail on Angela and Sheila. So Dr. Angela Kokeman has her PhD, her MSc, her BSc, and she's an assistant professor and lecturer in the School of Nursing and Psychotherapy and Community Health out in DCU. And Dr. Sheila Wickham has her doctorate in nursing science, her MSc and diploma in family planning, a diploma in diabetes. She's an NORGN, a registered midwife, and an RNT, and she's also an assistant professor lecturer out in the DCU School of Nursing, Psychotherapy and Community Health. And both of them, we're always proud to say, are fellows of the Faculty of Nursing and Midwifery, and we're absolutely delighted to have them here today to share their expertise with you. And I'm going to hand, there's 40 of you there now, which is just amazing. So I hope you enjoy this, and I'm going to hand over to our experts because, again, it's them you're here to hear. So enjoy the session. Just pop in any questions, and I know Sheila and Angela like to ask you things going along. Pop them into the bar. We'll read them and we'll present them to them at the end. And the other thing is there's going to be a little Microsoft Forms in there. Just pop your name and your email into that, and we'll follow up with you with your cert because it's approved for the 1.5 credits from the NMBI. So we'll email those together with the slides, but we can't email them if we don't have your email. So enjoy the session and talk to you at the end.
Thank you very much, Catherine, and thank you, Aisling. As I say, Angela and myself will start now. We like to give these sessions together. So even though we're a bit remote from each other, obviously, at the moment, what I will do, I'm going to start, and then Angela will take over for a large section, and then I'll finish up at the end. We've just wanted to recap from last week to begin with. Now, I know some people have been with us on all the sessions. Some people have only just started on today. Whatever, you're more than welcome. I would ask that if you have questions, or you can put them into the Q&A section on the side. We try and monitor that, and certainly at the end of it, we'll come back. We have time for questions and answers at the end. So just to keep it, give you a chance to interact and ask for clarity if we're confusing things, which we do on occasions, obviously. As I say, we're going to talk a little bit more about chronic disease. We touched on them last week, and non-communicable diseases, as they're commonly known, and they're an increasing problem and a recognised problem. We're going to talk about screening. Now, this is quite important. Angela will focus on the screening for metabolic syndrome. I'm going to talk about the national screening programs. It's quite interesting. We actually have 4 national screening programs. They're a resource we should all be using for our patients, and it's something I want to go through with those. Then, if I do find you have things, what are possible interventions? Making every contact count, which I hope you're all familiar with, is something Angela will focus on that, and the 4 areas they focus on their alcohol, smoking, obesity, and that. And then physical activity. I will actually focus on possible physical health interventions, not just touch on it. And it's something we were all talking about just before the session started, how we could talk on any one of these topics for the whole session. And finally, I'm just going to mention integrated care programs. They are part of the HSE. COVID has delayed them slightly, but they're coming down the tracks to us and they're potentially useful. So that's where we'll go from now. As I say, if you have a chronic disease, as all your patients with mental illness have, you have to have ongoing management. Very few chronic diseases are not progressive. And that is something that we have to be aware of. It requires change. Management will change from time to time, the requirements to manage it. It can occur at any stage of the lifespan, and certainly mental illness can do that, as can the other ones we're going to be talking about. And it has potential to have the long-term impact on your quality of life. The older you are, the more likely you are to have a chronic disease. And the thing about having a long-term illness, a chronic disease, doesn't just affect your physical well-being, it impacts on your emotional or mental health well-being as well. And that's something which we are very good, and Angela has certainly talked about the diagnostic overshadowing. We're great at either, depending who you see. If it's the medic you see, you'll focus on the medical problems. If it's on the other side in psychiatry, they'll focus on the mental illness. We need to look at this in the whole aspect. It's a very, very important part of what we do. This was Healthy Ireland, which you're all familiar with, from 2013. And what they forecast was chronic disease rising by 4% each year. So you consider that even since they published this in 2013, the impact, how much more we have, many more people we have with chronic disease. 1 in 5 of us will experience mental health problems in our lifetime, 20%. That's an interesting figure to give people, because it's quite a useful figure, particularly talking to people with mental illness who feel they're the only one in the world. Quite often they're not. 20% of us will have problems. And that's something that can be reassuring, that they're not in isolation. 1 in 10 people over 50 has diabetes, and that's a conservative estimate. 1 in 5 of our children are overweight now. 36,000 new cases of cancer every year. Cancer is now becoming a long-term, a chronic disease. We can treat it well. We can't necessarily cure it, but we can treat it well. With smoking, we're doing well. We have them down to 19.5, which is below 20. We want to get further down. We have the 5th highest alcohol consumption in Europe. And you look at your patients with mental illness. Unfortunately, a lot of those both smoke and consume alcohol. And half of all the people in this country have at least one chronic disease if they're over 50, and most have more. What we started, well, what the government started, was the National Screening Service. And the whole idea of this is we're going to screen the population to see if we can identify problems early and ideally treat them or prevent them getting worse. It has a huge part to play in disease prevention. The thing is, and Angela will talk about this as well, people with mental illness are very poor about attending for national screening. There's lots of reasons for that, and I'll go into them, but they are poor. And yeah, it's something, as nurses, as healthcare professionals, we have to constantly, and I know there's a lot we have to constantly think of, but we do advocate for our patients, we do fight for them, and we have to constantly think about them. When was the last time you asked any of your patients or clients, had they ever been for screening? And it's something to think about. It's a free service, it's a useful service, and if it saves one person, it's worth it. And that's, you know, I always have this idea, if I can just make an impact on one person, I've achieved something. Why we should screen? To diagnose a condition, to see if you have any of the long-term conditions, usually it's cancer at this stage, and retinal screening, obviously. To provide a health intervention, and it's something that was certainly with breast screening, if you are identified as having a potential breast lump or that, there's now quite a good service where you arrive, you have your biopsy, your mammogram, and you see the doctor all in one day. It's quite good. And that's what we can do. We can intervene, but we can only do it if we know there's a problem. Generally, we have found they're effective screening programs. They're clinically, socially and ethically acceptable, and that is something to remember. It is the nice thing about the programs, the screening programs, they're available to everyone who fits the criteria. It has both, as everything has, both benefits and disadvantages. It does improve your prognosis. You're far more likely to have less radical treatment, and it gives reassurance. And think about how important those factors are for your patients with mental illness. If I have mental illness, I don't need to be landed with, advanced cancer that could have been diagnosed by a screening. I don't need to be going for far more radical treatment than I would have had if I'd been screened, if I'd gone for that screening appointment I got a year or two back. And it can be reassuring for people who do worry about these things. Obviously, nothing is 100% accurate. It can sometimes lead to unnecessary worry and further investigations. And again, for patients with mental illness, that can be a challenge sometimes. They really don't want to be landed in for further tests. The argument of a longer illness, if the prognosis is unchanged, is a fair argument, but I think possibly outweighed by the benefits. With the 4 national screening programs, which I'm going to briefly go into shortly, they each have an individual register. Now, the data are collected from medical service, social protection, lots of places like that. But the thing is, are your patients on it? Is a big question. Are the patients with mental illness, are they on the register to begin with? They are not always coming from the most stable of backgrounds. They may have had to be moved or things like that, and it's something to consider. Now, ideally, you can get them to check themselves, free phone number, or perhaps you might want to do it sometime if you're worried about them, because it's a good start. Are they actually on the register? If they're not on the register, they'll never get called for screening. And it's a simple thing. And that's what I mean. This is a resource we have available to us. It's free. Well, it's not free. We all pay for it in our taxes, but it's free for a point of use. And it's silly not to use it. Breast check, most commonly diagnosed cancer in women. As I say, over 3,000 a year, 709 deaths per annum. But we're actually improving the prognosis of breast cancer, particularly when we get it early. And that's why we do it. It's available for all women between 50 and 64. Next year, we're moving that up to 69. They get a free mammogram. It's every 2 years, and it looks for early signs of breast cancer. It's not too invasive, maybe uncomfortable, but it's not too invasive. But again, how many of your clients will go for it or are even aware of it? Cervical check, and I know, and this is another one that has been so controversial in the last few years, but in fairness, even the people who have had problems with it would still, by and large, advocate people that women attend for cervical check. It's available for women between 25 and 60. Frequency will vary depending on age. At the moment, it looks for abnormal cells. Now, we're actually changing this. We're going to start looking for HPV. That's what we're going, and then depending on if you have positive HPV result, we'll send you on for a cervical smear. That was due to change earlier this year. Like everything else, COVID is being blamed for the fact we haven't fully changed on that this year. It'll be a less invasive and simpler test if we're just looking for HPV. But we have found that the number of people who get cervical cancer without having a previous HPV infection are minimal when we're trying to vaccinate for it. So it's something, again, to bear in mind. This is can be more difficult for some of your clients. It's more invasive and they may not be anxious about it, to go for it. So again, it's a case encouraging and asking. It's like I was talking about last week. If I didn't ask any of my patients about having hypos, they wouldn't tell me. Similarly, I expect if we don't ask, have you been for a check, for your breast check? If we don't ask, we'll never hear. And it's something to remember. And make small talk with it. As I say, screening process, they're sent out an invitation letter. They attend with a register, usually the GP, and they have to take it at a particular time this cycle. If it's not normal, they're referred further, colonoscopy. And any concerns between screenings doesn't exclude the need for GP, and that consult your GP. We always say that's very important. As we say, nothing is 100% diagnostic. So any of these screening programs, if there's problems in between time, they should feel free to talk to you or go back to the GP or wherever they had it done. Bowel screen is an interesting one. It's a more recent one, can be done from home, and that's where it's done. It's the second most common cancer in men, third most common in women in this country. And we lose about 1,000 people a year. Quite a lot of people. And if we could prevent that, wouldn't that be nice? It's 60 to 69. We're going to expand that. Again, I haven't got a year on that. And you see this test kit up. This is what the patient gets sent out, the person gets sent out. They take a stool sample and send it back. And it's diagnosed and it's analysed. And if it's positive, they'll get a result telling them to go and attend for GP, and they'll get a colonoscopy very fast. But usually, I'm 99. Most of them are negative. They get, they just get referred. They just get a letter to say that, and it's fine, and it goes well from there. So very simple test, freely available. Again, do patients, are they on the register? If they're not, and particularly with bowel screen, when we started this, what they were doing was sending out a letter of invitation. How many of your clients would be inclined to say, come back and say, yes, I want to take part in that screening? We have to push this. We have to ask them. And if it saves them some grief and some ill health, it's worth it. Now, you know me and diabetes, which is my favorite topic. And I spoke a lot about it. Blindness, it can recur as a complication of diabetes due to your retinopathy. There's blood vessels at the back of the eye. So we screen for this now in a number of areas. In Dublin, we do most of it actually in the Diabetes Ireland, where their offices in Santry have one on the south side as well. What they do is just, person goes in, dilate up the pupil, they take a picture of the back of the eye, and it's sent off for analysis by the experts. And that's all that's involved with it. If there's any changes, they'll call them back. It's a simple test to do. But again, how many of your clients, now one, I'd say half them have diabetes and we don't know about it because you don't. But even the ones you do know, how many of them are going for this screening? I mean, this is what we talk about, normal vision or vision with diabetic retinopathy. It's a hell of a difference. You try reading anything with that and the impact that would have in their life. If you had problems with your mental health before, that would be enough to depress anyone, wouldn't it? So it's these factors we have to focus on. They talk about barriers to screening. People are afraid. They're sometimes afraid they don't know what's involved, or they may just be afraid that they might get a result, a positive result. Lack of knowledge. They may not know the knowledge exists. Now, I, as you know, would work with the student nurses as well. You'd be amazed how many of those can't tell me that we have 4 national screening programs, or even if they can tell me, they couldn't name them for me. And that, unfortunately, is not unique. I'd say I get that if I spoke to any group of healthcare workers. So it's, you know, if we don't know ourselves, what hope have we for the patients? Lack of education, that they don't or may not be aware of the potential benefits of it. Socially isolated. And that was an interesting one. I remember a few years ago, they had the breast check and they were trying to, and it was the women going, oh, I got called for my breast check, I'm too busy for that. And it was the pressure of the other women going, oh, you have to go for that. And it's that idea, if how isolated are some of your clients? So that even if they did get this, who could they talk about? Where could they get positive encouragement to do it? Culturally isolated. And again, with our diverse community in Ireland now, some people would not be comfortable going for certain screening unless it could be guaranteed that it was going to be a female or whatever, or it wasn't going to be a female if they were male, if they were man. So all that. Time, lack of time is a great excuse. We all use it. Geographic location, it depends where you are. I mean, I mentioned the Diabetes Ireland screening in Santry. It's an awkward place to get to. It's sort of, you know, opposite IKEA and in that lane, but you wouldn't, you know, it would be difficult to get a bus to it. And that's for people in Dublin. If I was further away, as many of my clients, they cover the whole northeast, how would you manage? They're all factors that will impact, and they're factors you need to be just aware of when you are talking to your clients and patients with it. But you look at that list of factors, that would apply. Most of those could potentially apply to people with mental illness, couldn't it?
Yeah.
On a day-to-day basis. So, as I say, it's just the odds are even more stacked against them. And that's where when we talk about what would help, you will potentially help. You by being positive about it, you by asking about it. It's there, it's free. They are entitled to have this service, and they need, you know, we just want them to use it. So basically, that's, I'm going to hand over to Angela now. She's a bit more on the back up on the screening and the problems that people are not going for screening, and then she'll talk about MEC. We have 4 national screenings. They're population based. We screen people who are asymptomatic. That's the whole purpose of it. So nobody needs to tell you, I don't need to go for that, there's nothing wrong with me. That's when you need to be screened. All free of charge. Ideally, we will get something precancerous and prevent problems developing. But if not, if we get it early enough, we can treat better. And the question is, how many of your clients are being screened? And I would say not enough, because we have a huge failure to pick it up. And this is probably a bad year because we're only getting back on our breast screening and all that now with COVID, but we are getting back. And it's a good excuse to talk about it now, get people back and get people into the system if they're not in it already. So that's all. I'll just hand over to Angela now. Are you okay there, Angela?
Yeah, I'm good. Thank you, Sheila. Hello, everybody. Good to be with you today. I'm going to just maybe follow on from where Sheila left off. And the question she was asking is, how many of our patients get screening, or how much screening is taking place? And I hadn't really thought a lot about this until the last couple of weeks. And I thought I'll go in and look at the literature now. And I went in, and the most recent article I got there is 2020 article that came from Canada. And this was a longitudinal study, which is very interesting in that they were following over 1.25 million women who were going for cervical smear tests and screening. And in that sample, there was over 100,000 people, women who were diagnosed with bipolar and schizophrenia. And the interesting thing about this is they were able to see over time, you know, because it would have been back many times over the 5 years. And they discovered, not to our surprise either, that the women with the bipolar and the schizophrenia were less likely to undergo screening in the first place, didn't turn up. And if there were screening, if it did take place, it was delayed, you know, so it didn't happen when it should have, or they didn't come back for the second follow-up screening. So, you know, from that point of view, this research suggests that there is a huge barrier there for females going from the cervical smearing. And you're right, Sheila, you did say earlier that it is a very intrusive kind of an examination, and the fear is there, and the lack of knowledge, and all the barriers that you pointed out are very obvious when you look at this paper of why women with bipolar affective disorder and schizophrenia are not, you know, having their cervical smears like the general population. And that is more than adequate evidence to prove that, you know, there is an issue there. I looked at the next article that I found, which was to do with barriers. And this is a study that came out of the UK. It's out since 2016, but it's a very interesting article, and it's a very good article. And we always talk about the importance of listening to our clients and finding out what they feel and what they know and what they want. So this is their narrative. And it was a study that took place in around London area, and it had 45 mental health service users who were interviewed. That's a lot now, it's hard to get that many, but 45 who were eligible for different types of cancer screening. And as well as interviewing the service users, they interviewed the health professionals who were looking after them. So they interviewed 29 of them. And they also then went to the other end and they looked at the people who were doing the cancer screening, and they interviewed 11 of them. So they were trying to kind of find out what the barriers were for the client, for the health professional, mental health professional, and for the people who were given the screening out. And this is interesting because they came up with lots of themes from it. Okay, and the next slide shows you that they had 5 themes that they found. And the themes were all around to do with the knowledge that the people had. Okay, so specific barriers to cancer screening for the mental health service users. A lot of them were that, you know, the biggest thing of all was that there was lack of integrated care, that they didn't know a lot of the time why they were going for it. There was information processing problems that they couldn't get their heads around. The screening process, maybe they felt it aggravated their anxiety and, you know, made them feel more maybe at risk. There was problems in getting to the appointments, as Sheila said. You can't always find that place in Santry, so the appointment difficulties were probably transport difficulties, or trying to make the appointment, or even difficulties leaving the house due to the mental health problems or anxiety, or for some people maybe even getting time to go there. So there's lots of different problems. The service user also felt a little bit worried and stigmatized. They were embarrassed, or they felt traumatized by going there, you know, that they didn't have a relationship with the person who was screening them. They mightn't know them, and they were nervous and they were uneasy about that. So, you know, from that point of view, there was lots of things that we could improve perhaps for them, you know, that they fear we could relay their anxieties, or maybe the transport issue, maybe we could organise maybe a transport system to get there, or reminders. I mean, we're all using our phones now for text messages and for, you know, little reminders of where we're to go and what we've to do. So there was lots of things there that we could address in helping to break down some of these barriers that our clients have. And, you know, I think the best evidence was just coming from that the mental health professionals also, big message for us as nurses, that we lack knowledge of the programmes. Hence Sheila's very good undertaking and going through the 4 cancer programmes here, because it said that lack of knowledge was a big thing for mental health professionals, and that promotion of health screening wasn't prioritised. That's considerably worrying, considering that we could save lives by doing this. So there was a lack of information on physical health expertise among the mental health professionals. So from that point of view, the much work could be done by mental health professionals in advocating the need for cancer screenings, and, you know, any of the 4 screenings that we've just looked at would fit into this category. So, you know, a lot to be learned from actually doing those type of interviews and speaking to patients, health professionals and service providers of screening programs about what we could do. So the next slide looks at, Sheila, what is the next one? Yeah, the complete barriers. Yeah, looking back, I mean, I did look at some other articles as well, but most of the articles, they're the 2 that would come to mind, but most of the articles would say that people with severe mental illness, our clients, do not receive an invitation to screening if they're hospitalised or if they're not registered for a GP. Now, I assume most of your patients would be registered for a GP, but sometimes we get people who move across services, or who move from different counties, from one county to the other. We have people who end up in homeless service or drug and alcohol service. So we've got a kind of a population that's transient and that move. So when that happens, they may well not have an invitation to screening because of that. Again, as I said already, lack of knowledge among us mental health professionals about national screening programs, how to access local screening programs, and how to use those free phone numbers. It also said that the whole of the multidisciplinary team really were not very well versed on what screening their patients were eligible for, looking through the different categories of patients from male to female. So that was important. There was patient-specific support needed. You know, those in long-term care often have a combination of problems, which means they need support to access the services. They may need transport. They may need us with them. We may need to bring them to the screening place or whatever it is to help them through it. There is also, I suppose, because of people with severe and enduring mental illness, there's a problem with cognition. There may also be a problem with literacy. You know, the presentation of the screening process may have to be adapted for those, because they may not be able to read the information that comes. It may have to be simplified, and it may have to be time spent on patient-centred explanation of why we're doing that. And we'll do that in our MEC when we move on to talk about what MEC is all about, but it is about making it more patient-centred. We also know that going for screening, any kind of screening, increases anxiety. It increases anxiety for the patients, and it might also do it for you, for staff who are unsure of what the screening entails. So, you know, the best way to overcome all that anxiety is all around education. So the anxiety can be, you know, because it's off-putting for them if they don't, you know, if they don't understand why they're going. So for you as staff, having a day like this where we can sit down and look at the screening programs and understand how they work is very important, because it helps us then to help the other. And that's what hopefully that's what we're trying to do, help our patients. And you're right, Sheila, if we only do it for one person, we're saving another life perhaps. So from that point of view, it's very important. Our next slide moves nicely on to what we can do, because we're talking about screening and intervening. A lot of the time we talk about screening for metabolic syndrome, and it's a good thing to screen, because then you'll know if somebody has risk factors, cardiovascular risk factors, diabetic risk factors, you know, and of course the problem of obesity. So we screen to find out who's high risk. But unless we intervene, screening is of no use. So we have a way of intervening now, and it's built into the HSC education system, where we talk about making every contact count. It's called MEC for short, MECC. And MEC is based all around the whole idea of motivational interviewing. And we're familiar with that as mental health professionals, because a lot of our conversations and our therapeutic interactions with patients is about motivational interview, and it's about, you know, trying to get them to think about something or moving on. So it's a health change behavior framework. That's what it really is. It's about, it gives you kind of guidelines on how you can help people around behavioral change, about improving their lives. And it's a plan really that useful for us as health professionals. It's given to nurses, doctors, GPs, who else? Social workers, everybody, physiotherapists, everybody in the multidisciplinary team can use this approach. It's developed and rolled out by the HSC. And it was rolled out basically to address the problem of chronic illness. As Sheila said, chronic illness is something that we can prevent, you know, like smoking cessation prevents it, diet and exercise programs help prevent it. So it's all about empowering the person to help themselves. So it really is about, mental health professionals are now asked to make this MEC count and to incorporate it in every contact, every routine contact that we have with our clients, in order to look at disease prevention. So each time we meet a client when they come to our clinic, that we ask certain questions that might make a difference to their overall life. So the core aim of this MEC, making every contact count, is about chronic disease prevention. It's about, you know, implementing something that's going to be useful to them, because we've screened, we know what illnesses they might have at this stage. So now we're trying to intervene. And there's 4 big ones that they look at. And the 4 big screening that we all around: alcohol and smoking, obesity and diet, and the last one's about inactivity. So, you know, it's about, you know, focusing on those 4 big ones: alcohol, harmful alcohol consumption, tobacco use, still smoking going on, not as much. I mean, it was what, 23% a number of years ago. It was down to 19%. I think it's still dropping. Sheila would be the expert on health promotion, but I think it's about 17 or 18% of the population now smoking, which is a big drop over the years, but we still see a lot of it in mental health services. Physical inactivity and sedentary lifestyle. We know what that is, because that's one of the core symptoms that we see in both schizophrenia and in major depressive disorder. So we see a lot of sedentary lifestyle. We see a lot of unhealthy eating, a lot of that due to perhaps side effect of certain medications, or maybe just, you know, lifestyle. So they're the areas that this health promotion MEC is all focused in on. And when we go on to talk a bit more about MEC, chief aim, chronic prevention. Yeah, it's about a brief advice. It's not something that you'd spend hours and hours on. It's about a brief intervention. So when we talk about motivational interviewing, it's not something that's going to go on for a long time. It could be while you're taking a blood pressure. You'd be saying, you know, did you go for a walk this week? Or, you know, or what kind of food do you like to eat? So it's about that short little intervention that you would have on a 5 or 10 minute consultation. It offers this short, opportunistic intervention. Now, a lot of people wouldn't have the chance to do that. So, I mean, when we get the chance to have that opportunistic chance to talk, we have the patient all to ourselves in the clinic. That's a great chance to do this. The aim of the brief intervention is just to raise awareness, and maybe to try and link something in with the risks of chronic illness and the risk factors. Then, you know, we go through a number of the risk factors each time we meet, and to give them some information about behaviours that they need to avoid, or to equip people maybe with new skills that would help them into the future. New skills maybe about doing a little 30-minute walk, or maybe looking at different things they could be eating, or, you know, maybe thinking more about the harmful effects of smoking or of alcohol. So they're the small things that count, and they're the things that we talk about. So making every contact count will focus on these things. So it's kind of useful that we have this, because this is really what we need for physical health interventions for people with severe mental illness. Like when I read the big articles about metabolic syndrome from any of the Hurt, or any of the ones that I read, Lotte Cornell and Van Pank and all of the big authors that write about the physical health illnesses in people with severe mental illness, they all talk about this is what we should be doing, looking at inactivity, looking at obesity, and also, I suppose, looking at smoking and alcohol if that affects your patients as well, because these are things that are going to cause chronic illnesses, and these are the things that are going to kill them. More likely, the more of these things that are present as comorbidities, you know, the less you're going to shorten the lifespan. And we've already talked about the mortality in our clients is between 15 to 25% of the general population. So they're losing 15 to 25 years of their lives because of these things, because, you know, we know that these are contributing factors. And when the HSE were developing, you remember we talked about this last week, they have the new health assessment documentation, 5-page document. The top bit there is just the first page of it, where you get all of the patient's health information. But you might remember on the last 2 pages, pages 4 and 5, I think, there was interventions that looked at, say, for instance, they looked at tobacco use. And they asked one pertinent question here. They asked the client, do you smoke? And if you do, how often? Less, you know, and then things like, have you ever thought to quit smoking? And, you know, they're just trying to gain information, okay? And so once the information is got, the intervention's on the other side. So what we do now? So we ask the client, have they ever considered smoking cessation? And if they you signpost them, basically put them through to the helpline or the www.quit.ie. So you're kind of given something for them to work towards, and you're planning that maybe as maybe a goal, a short-term goal or a long-term goal in their ICP perhaps. But you're bringing, the question has to be asked, because you won't be able to give the intervention bar you ask that question. So the first question they're asking there is about smoking, and then the MEC is built into this. That's MEC on the other side. The intervention is definitely MEC, because the HSE have the interventions there now. They have the smoking cessation, different things that can be used in there, and smoking medication that can be used. And then if the patient's not interested and don't want to talk about it, I'm smoking, I'm going to keep smoking, that's fine. The patient has declined and is not interested in quitting at this time. So literally you're ticking a box, because you've rose it, and you know, you're not going to browbeat anybody, but you've rose the question, and then you can tick the box to say, okay, they haven't taken a hop this time, but you can be revisited. You know, so that's the first one they look at, is smoking. The next one they look at is alcohol use, yeah. And they have 3 questions on alcohol. So they're asking 3 different questions of your client who comes in with drug and alcohol, particularly alcohol in this case. They're asking about how often do they drink? And then you're trying to sign once a day, once a month, whatever. And then they're asking you how many units do they drink on question 2. So that's giving you more information. And then you're looking at abuse of drink. How often do they drink 6 or more standard units? So you're trying to get a score. So you're scoring it up there. So once you get the score, then you'll know if it's low risk. If it's between 0 and 4, you know that it's low risk. So you're saying that's fine. It's not fine, but it's okay. But however, if the person is scoring 4, 4 and 4, so they're ending up with a high score, over 5 even, you know that there's a problem drinking there. And there's questions then. The intervention is, you know, that you talk about the risks, short and long term. You talk about the benefits of cutting down. You talk about strategies that they can use. And again, the HSE drug and alcohol helpline is included there, or you recommend that they discuss it further with another member of the multidisciplinary team. All of these things are useful, or you refer them maybe if they feel, if they agree with you that it is problematic, maybe to substance misuse advice. So all of these things are useful in that the intervention is built in with the questioning, with the MEC question, so that you have, you know, all of your brief intervention is encapsulated there in that you rose the topic, and then you provided some kind of intervention or something that was useful for the client in that brief intervention. And that's the alcohol. And the next one we looked at was the body weight. This is where we deal with the problem of obesity or underweight, indeed, in some cases. So this is where we look at, has there been a change in a person's weight over the past 3 to 6 months? Yeah. Are they taking maybe some oral supplements? Have they got swallowing problems? Maybe have they difficulty eating, or have they self-induced vomiting or binging? So we're kind of trying to get an idea of where they might be with their diet. And then we're looking at their BMI status. We can tell a lot by BMI status. So that's why that's built into our metabolic syndrome. We look for height and weight, we work out BMI, and we also include waist circumference, because it's important to compare waist circumference regarding metabolic syndrome. And once we get BMI, then we'll see what category they're in. You know, either they're underweight, healthy, overweight, or obesity. And we always worry about the ones that have BMIs of over 30, because we know that that might lead to significant problems down the track. And then the interventions on the other side. So if they're underweight, and we might think they're problematic of that, we would refer them maybe to some member of the multidisciplinary team. If you have a diabetic, or diabetic services, not diabetic, if we have a nutritional dietitian, we might refer them to that, or for nutritional screening. If they're a healthy weight, we just talk about the importance of maintaining healthy weight, maybe give advice on, you know, healthy diet and exercise. You know, if they're not interested, we'll say that's fine. Then we move on to somebody who might be overweight. And again, the same thing again. We look at strategies for weight reduction. We look at self-management around that. Maybe we might even be thinking referral to dietitian, certainly for somebody with a BMI of over 30, and we often have patients with BMIs of 40, and it is difficult to, you know, to try and engage in that. But these brief interventions are about talking about it, about signposting people to HSC services, and definitely referring them on to the dietitian at this stage, you know. And if they're not interested, you know, again, we can't force anybody. There's a tick box there. The service user is not interested or declined, and that's fine, you know, because you can't, at least you have to say that you've discussed it, you've opened it up there. That's one thing about MEC. They're very clear on, you can only go so far. You can't force somebody to do some intervention that they're not willing to do. So you can just raise the question and see where they go from there. And if they have this diminished capacity or power of reasoning, then we can't deal with that. And there is another little tick box there to say that maybe there might be a need to involve a family member or carer if they're living at home, and if you thought that the carer might be able to help them with their nutritional needs or with some advice about diet, well then we'd include them in the intervention. And the final one that the MEC has in the HSC assessment is all around physical activity. And we do talk a lot about the importance now of physical activity. And this is one of the questions we would ask, you know, how much activity is a person getting? Do they engage in some sort of physical activity for 30 minutes or more? And then we see if they do that every day, or maybe only once a week, or maybe never. So we're trying to capture that information to see how many minutes they might use on physical activity over a day or over a week. And then the intervention is on the other side, and the intervention is very simple here. We just talk about the benefits of physical activity. We signpost them again to getirelandactive.ie. We've plenty of websites for that. When we're doing our 5 or 10 minutes intervention with our client, when we have them at a depot clinic or at a Closwell clinic or wherever they are attending or just coming in to see us, we talk about these things and we signpost them. If they're not interested or declined, well then we have to say we've tried, they're not interested at this time. So we sign off on that and say maybe we can revisit that. And we often say to them, is it okay if I talk about this maybe next week or next month, or maybe when you're feeling better? So we can do that. Again, if they need help, if they're living with a family member or a carer, it might be important maybe to say to the carer, is there anything we can do to help the person? So I know, Sheila, you're going to talk about the importance of the exercise later on, but the 30 minutes is where we're at really with this. And this activity should be kind of leisure activity. They shouldn't be forced into it. It just could be something like going for a walk, doing something like what they always do maybe, rather than just having it all pre-planned. What you will notice at the end of this document, it does say that all information in the physical health assessment should be included in the service user's ICP. And I know that the Mental Health Commission are very clear on this now. They do look at ICPs to see what are the interventions that we're doing for physical health in the ICPs, particularly around exercise. and diet. So for that reason alone, this particular document is useful for us. It's a great little document for us to use. I did mention Mental Health Commission, and here he is. Mental Health Judgment Support Framework, you know the regulations better than I do, but you know that Regulation 19 is one that particularly looks at the general health of our service users in our approved units and in our hostels. And it talks about the roles and responsibilities of, you know, the people who work in these areas. And it talks a lot about everybody having their physical health assessment and it being incorporated into their ICP. It talks about screening processes should be available, and it talks about the support of healthy lifestyle choices, and that would also be in one of the other regulations that looks at therapeutic interventions. So, you know, the framework document now is certainly geared in to find, you know, all of these things to when they come to do their inspections, that these are particularly, you know, Regulation 15, they definitely look at Regulation 15 and the therapeutic interventions, but they always kind of now in recent years are very concerned about Regulation 19, so they do look at this one. And when we move on, I know that the next slide is Dr. Susan Finnerty is one of your inspectors in the Mental Health Commission. And last year she produced a report, short little report that she had carried out herself, looking at physical health assessment and monitoring of people, our patients with severe mental illness. Now these patients were in residential hostels, okay? These are hostels that are staffed 24 hours a day, well mostly 24 hours I expect. And she said that these hostels fell below international standards, particularly in relation to Regulation 19. And the hostels that she reviewed, she found that only 9% of clients had their waist circumference measured or recorded. That would be kind of not very good, because we know now for metabolic syndrome that waist circumference is a key indicator for determining metabolic syndrome. So not having your waist is kind of a big error there. And she also found that 25% had body mass index recorded. So that means a lot of other people didn't have body mass index recorded at all. So we couldn't even tell where they fell within the BMI range of obesity or not. And she said even though they had lipids, they had their blood lipids taken, and a lot of them had ECGs carried out, they still were missing the more important information that we determine metabolic syndrome from, and that would have been, you know, waist circumference and fasting blood sugars and blood pressure. So the information, whatever way it was gathered, was probably gathered very ad hoc rather than, you know, being seriously looked at from a planning point of view. Her report finishes and says these findings are a serious concern and show that residents in long-term care and mental health inpatient units have not been adequately monitored for serious physical illness. And she said it's particularly in light of higher risk of developing serious mental illness than the general population. And I remember the morning this was published, I heard it in Morning Ireland, and I just thought, oh, you can't wait to get my fingertips on this to see what this is about, you know. So, I mean, people pick up on this, you know, and it's like a bad Hickory report. When it gets out there, everyone wants to know, oh my God, how did that happen, you know. So I think it was a bit of a wake-up call, and I do look at the Mental Health Commission website, and I do look at the reports that come in from various centres around Ireland. And I'll often see where they fail on this Regulation 19 and sometimes on Regulation 15 as well. But this particular one, it's easy to find faults if you're not following, you know, the recommended best practice. So from that point of view, it's a pretty damning report to have on our hands from the point of view of 24-hour care and nurse-led care in these centres. So we have a lot to do still to, you know, to reach international standards of best practice. And moving on. You remember last week somebody said to me, have I looked at the Lancet report? I have, of course, yes. The Lancet Psychiatry Commission, a lot of psychiatrists, I think it's at least 30 psychiatrists came together to write this report. It's a big document, it's 34 or 5 pages in it. And this blueprint for protecting physical health in mental illness was published just this August 19, sorry. It was published last year. And it's one of the ones that's talking about raising awareness about the issues. It's a huge document. I mean, you'll pull stuff out of this for the next 10 years because it's so evidence-based. But they talk about the issues first, and the issues are to do with the increased rates of smoking and bad diet and exercise, and that's leading to premature mortality. They talk about the prescribing of certain psychiatric antipsychotic drugs and the side effects, and they talk about the inadequacy of health promotion activities leading to unhealthy lifestyles and a cardiometric burden. So they have all that already highlighted there. And down underneath, what we're always saying and what we said last week, and I know somebody was really concerned about this, that we have a fragmented or inaccessible physical and mental health care in Ireland. You know, that we don't link our primary care GP very much with our secondary care, what we are, psychiatric services. So we've a bit of a gap there between, and a lot of our patients fall between this gap. All the issues are up, smoking and all the inactivity, and then we have this gap down underneath that we're not addressing. And the second part of this slide, the next one, actually shows what we should be doing. And this is what the big document is about. The Lancet document is about health promotion, more clinical care, and they also advocate for further research. So they're talking about health policy, about addressing behavioural risks, early intervention and evidence-based lifestyle programmes. Now we can do that because we know the evidence is there and what works and what doesn't work, so we can do that. They encourage psychiatrists around the whole area of prescribing, and they're still concerned about psychiatric prescribing of particularly antipsychotic drugs, and maybe putting in more cardioprotective proper drugs that would be more cardioprotective towards the client. The next thing they introduce, and I see a lot of new articles coming out on this, is about digital technologies for monitoring and promoting health. And we looked at digital technologies and we talked about the importance of, you know, using the smartphone to help the client. And they also mentioned then about increasing access to integrated care, and that's something that we're very keen on encouraging and promoting. I don't know when we'll get to it in Ireland, but certainly an international standard that we should be achieving is the importance of integrating physical health care, providing more interaction. We see the circle is complete there. So we have our psychiatrist, we have our GP and our hospital and our monitoring. So we have everybody talking to each other. That circle is meant to show people are beginning to converse and talk to each other from both primary and secondary care. So if we do that, that's the way forward for us. That's really what we're looking at. Finally, I'm going to talk just quickly to show you some nurse-led interventions. And I know the next slide looks at, I picked up a couple of articles, but I'm going to only point out one or two to you. There's an article that came from Spain, and it was looking at the effectiveness of community-based nurse-led lifestyle modification interventions. Now, this is unusual in that we very seldom get randomized control trials with psychiatric patients regarding interventions, because usually when we give an intervention in our settings, we give it to everybody. But in this case, this Spanish study, they divided 61 participants in 2 different mental health centres. So one crowd got the intervention and the other crowd didn't, and they started baseline the same, very similar subsets of patients. They gave a 20-minute theoretical, so information about diet and exercise, and then 60-minute activity, nurse-led activity. So, that was pretty full on, that they were able to manage to do this. And, they did find huge benefits from this. The intervention showed really good positive effects. Those who got the intervention, it reduced their cardiovascular and their metabolic risks, as you would expect. But the most important thing, that the physical activity, it improved their quality of life. They felt better. They were out, they were moving, they just felt better than the group because they did quality of life tools incorporated into the measurement of all this. So, we can't underestimate the importance of an education, a brief intervention, theoretical education around diet and exercise, but also helping them to do the exercise, because the motivation isn't always there to do it on their own, so that the help with the intervention really worked. But the only thing about this is you have to continue it, because the next, I've often read articles before, the next article actually from Fraser, which is a lady in Brisbane in New Zealand. She actually only did one intervention with one group of patients, 16 of them. And again, they carried it out over many weeks, 6 or 8 weeks. And you know what they found? Unfortunately, like what we all say, the brief intervention has to continue, because she said the behavioural counselling, even though it was good, it has to be sustained over time, because what happens is, even though they did it and they measured after 19 weeks, they found that people slip off the, what do you say, Sheila? They slip off the wagon. Yeah, people slip. the wagon wheel falls off. Okay, like us when we go on a diet, the wagon wheel fell off a lot of these people. So it needs to be sustained over time. And the other thing I actually liked, and it's a very Australian thing to say, an open door policy for attendance, because there can be interruptions in people's lives, you know, and there can be hospitalizations, and there can be times when we feel miserable and it's too cold or it's too wet to go out or whatever. Although in Australia it's probably not that cold, but it could be too hot to go out. So, you know, she said give people leeway, let them fall off the wagon, but as long as they're feeling a bit better over time, that's really what we're looking for. We won't see significant difference in weight or physical activity over short term, but if we can sustain it over long term, maybe much more than 19 weeks, probably looking at over years, certainly over a year or longer, we might see a benefit of that. So having a drop-in place, you know, like a drop-in place where they know every Wednesday we're doing this health intervention and they can come without an invitation, just pop in, that would be good. Or if you want to send reminders by text to say we're running an intervention every Wednesday, come in if you can. I was thinking of AA when I read this. I was thinking that's a bit of a real AA program, isn't it? That you can come in and tap and take what you need out of it and go again, you know. So from that point of view, I think it was a useful way to do some interventions with people with mental illness. And finally, I'm going on now, Sheila. Yeah, I'm talking again, just to bring it back to why we're doing this. We talked about risk factors, we talked about screening. You know that Sheila talked about 4 cancer screenings. Your screening for metabolic risk is really important, that you're looking at obesity, high blood pressure, high fats and high sugars. But you know, when you think of those 5 things up there, think about interventions. Always think I can do more with healthy diet, with weight, healthy weight, with physical activities, by getting them to decrease their smoking, and even managing stress. Even our stress management interventions are all going to be hugely important from the point of view of physical health and physical activity. So, you know, from that point of view, you know, there's a lot we can do, and there's a lot, we have lots of tools now at our hands. Don't forget MEC. MEC is there as your tool for prevention. That brief intervention is so important, and we underestimate the value of our time with our clients and what we can get out of it. So, and we underestimate ourselves with regards to documenting this as well, that we always document any brief intervention we do, because I can tell you a lot of other health professionals write pages on their interventions, and they see a patient for 5 minutes, and we could be there for 24 hours and write very little. So, you know, please always document what brief interventions you do, particularly around, you know, the whole area of metabolic risk and about the prevention strategies. I'm going to hand you back to Sheila now, because you want to talk a little bit more about physical exercise and physical activities.
Thank you very much. And you'll find like we each other a lot. We do. Certainly in regards to physical activity. One, how much should we be doing? And we all know what we should be doing. You know, at least 60 minutes per day. Adults, 30 minutes. Older people, at least 30 minutes. And adults with disability. So at least 30 minutes exercise a day. Now you think again to your population of patients with mental illness, how many of them would actually fit the criteria? And it's back to this idea as well of what Angela says about every contact. Make every contact count. Even if you just mention it, maybe they don't want to do it this week, doesn't mean you can't say it again. How are you getting on? Maybe they might be feeling better or whatever. They might have a reason now. The reason we're so pushy about exercise and why we want to do it, it can make a difference. It can actually reduce heart disease, a risk of heart disease and stroke. It actually can also reduce cancer, which people aren't always aware of. It slows down or prevents the development of chronic diseases. It certainly enhances mental ability. So people feel better if they exercise. You tend to sleep better, you have better energy levels. It certainly can improve depression and help people manage stress. And you know that yourself. How often when things are getting on top of you, if you can get out and have a 5-minute walk, it can make life better. Certainly if you're exercising regularly, weight can improve, which is something we encourage in as well, that we want them not to be overweight. That'll improve patient self-image, and therefore they'll feel better for those reasons as well. So exercise, very simple thing in some ways, but it can do a lot for you generally. As I say, the additional things like reducing your risk of type 2, you're strengthening bones and muscles as well. and it increases your chances of living longer. We looked at how active people were in our Healthy Ireland survey, and in fairness to Healthy Ireland, they didn't just produce that document, they actually regularly audit where we are and things. And in relation to physical activity levels, they did that last year. And they're quite, the Healthy Ireland survey results are out every year. I couldn't get the 2021 because again, COVID has delayed it slightly. The people who normally process the whole thing are deployed elsewhere. But this is the 2019 results. And if you ever want figures to support what you're doing, I would recommend you look up Healthy Ireland survey results. We look at only 46% achieving the minimum level. Now, okay, that is an improvement on where we started, but it means that over half of our population are not even doing the basic minimum level with it. 54% men are better than women at achieving the minimum level. Now, the interesting thing, and this again, which I've always feel as well, those living in more affluent areas are more likely to achieve the minimum level than those in deprived areas. Where do most of your clients come from? Most of them are not coming from the more affluent areas. And the fact that 8%, nearly 10% of people said they had participated in no physical activity during the previous 7 days. You think of those figures, if they were applied to your population, I feel they could actually be worse, you know, so it's something to think about. From the point of view of mental health or physical health, physical activity, it can help depression, both prevent it and also reduce it. It works very well as an antidepressant. And that alone, on your clients who are on so much medication, wouldn't it be nice if we could replace one of them or reduce one of them and replace it with a bit of exercise? Think about physical activity, and I know Angela was giving you the ideal that you want the 30 minutes a day, and we all want the ideal, but anything is better than nothing. And I would always believe it can be useful sometimes to start slower with somebody. So when you are talking to somebody, you don't want them out running marathons or joining gyms. That wouldn't be what they'd want. And certainly if they're starting from a very low base, it's certainly not where you want to push them. But what you can do is suggest walk up the flight of stairs when you go home, you know, or when you come into the clinic, rather than take the lift up to the first floor to see me. Simple things like that. Walk down to get the newspaper, you don't have to drive. Very little simple things like that can make a difference. And it is entirely this idea, some physical activity is better than none. Angela talked about the use of IT and technologies. I think a very simple technology, which is available to a lot of them on their smartphones, is step counters, that they can actually tell you how many steps they are. And again, it gives patients more control, clients more control of what they're doing, and it allows them to monitor it. The snag is you have to be able to remember to ask them as well. And I appreciate there's so much you have to check with them and so much you have to ask. But remembering to ask, how's the step counting going? You know, are you building it up? And it's to set achievable goals. Well, see, could you improve that even by 100 steps by the time you see me next week? And it's things like that. Also, let them do things they enjoy. There's no point in suggesting people jog if they hate running in every shape or form. If their idea of exercise is walking the dog, grand, I'll take it. If their idea of exercise is swimming, grand, you can drive to the pool and swim. It has to be something ideally that they get pleasure out of as well. How much activity we do as health professionals also will impact. If they never see me move, they're far less likely to take the message of you should be more physically active. Because as well as that, you can empathize a bit more, saying, I know it's hard, and it is hard. We've all had great ideas that we're going to walk every day, and I'm sure we all had it during lockdown, that we're going to do so many steps per day. How many of us actually got them done? You know, so there's all these factors. The weather can be bad. And the thing to remember is, as Angela says, we fall off the wagon on occasions. It doesn't always, that doesn't mean they can't restart. And it's to be positive about that and to give that message. Chronic diseases are just that, they're chronic. Physical inactivity can help alleviate the development or progression of chronic diseases. But equally so, it can be something that we might forget to do on occasions or forget to think about it. So it's encouraging people to get back all the time, if that did happen. As I say, ideally get them to fit it into their everyday life. And sometimes you walk up and down the stairs 2 times during the day. Something is, so you set achievable goals. Certainly you don't have to do it all at once. You don't have to go and do 30 minutes of exercise every morning or 30. You can do little and often. So you can do 5 or 10 minutes a number of times a day. It should be fun, and enjoyment is important. So ideally, if you can work with somebody or, you know, have a buddy with it, that can sometimes help greatly. And that enhances the whole idea of social interaction as well for them. No, difficult at the moment with lockdown, but and encourage people to be active in their own way. And that's what I'm saying. Some people love walking, some people like running, some people will swim, some people get on the treadmill and that's what they do because they have one at home, or step. Whatever they like, I don't care what it is. If it gets them moving, gets them active, that's a good start. And the thing is, we have to remember to ask about it. As I say, before I go into the integrated care programs, physical activity should be part and parcel of what we do every day. For a lot of your patients, and as you say, they are clients, they will have episodes when their mental illness may have been exacerbated for some reason. So maybe for a week or two, they weren't crossing the door. They didn't do anything. That doesn't mean the next time you see them, you can't encourage them to start back. And they may have gone back a bit, so you're starting from a low base again, but always encourage it. And the snag is, and I know how busy you are, is to remember, like, and here we have, you know, we want you to do MEC, we want you to check about the screening, I want you to check about the physical activity. It's such a lot. But again, I just have to build it in to what we're doing because it can make such a difference and make people feel so well. Simple steps. I just wanted to mention the integrated care program, which the HSE, and it's important that we know. Now, Angela doesn't always believe me, I think. I would say that those in mental health, because you're used to working in multidisciplinary teams, are well ahead of the curve on this. This is this whole idea of involving people to manage their own chronic disease. And it's a team effort to manage your chronic disease. We would say the patient is one of the most important people in the team. The HSE has established an integrated care program to deal with chronic disease. And the aim is to provide a continuum of preventive management and support services to patients with chronic conditions with it. And as I say, involving general practice team, that there's a framework being developed now with 4 areas working, and the peds and gerontology are more active at the moment. Chronic disease itself is coming later, and again, COVID has slowed us down this year with it. And it has appointed some care program managers, but not all of them with it. So what they're aiming for, a model of care that treat people at the lowest level of complexity that's safe. And we want to stop getting patients involved. And you think of it, and that doesn't mean you're well ahead of this in mental health, because you do treat people in the community much more so, and stop them having to drag them into the institutions, healthcare institutions. What we want to do though is, at the moment when people say multidisciplinary teams in mental health care, they focus mostly on the mental health. We want the physical health involved in that as well, and that's where you do. And as I say, there's a long way to go in all areas. This is where we are at the moment. The older people and children are up and running. Patient flow is further down. The prevention and management of chronic disease should have been further along this year, but because of COVID, it has been slowed down a bit. So not quite as far as we'd like. But it's the whole idea of the patient, if they have issues, be it they have mental health issues, but they also physical health issues, and it could be their obesity, could be their diabetes, but they should be able to see a dietitian, they should be able to see whoever they need within the community, and they should have an involvement and a say in all this management of it. And that's what we're trying to develop much more so this. As I say, it's a big part of Sláinte Care was the development of this too, and it's trying to be pushed out at the moment. So you will hear an increased amount of it. Just like MEC, it's part of HSE. I'm hoping, by the way, that most of you would have done your MEC training by now. If you haven't, you can do it online. It's available to log into HSE once you're a member or an employee of the HSE. You can log on online and you can do it. And it gives you the whole, it's 7 little sessions. They don't take that long and they're quite useful.
Mm. Yeah.
So that's all I have to say for now.
Yeah.
And
Thanks, Sheila.
We can hand over to
Questions.
questions and answers.
Yeah. Thanks, Sheila. I appreciate there was a few people who have sent in little texts to us, and I've been looking at them there over the last 5 minutes or so while you were talking. So it's just where you can access the MEC screening tools. And again, I've been looking at the HSE website, and the MEC page is in there, and there are the resources in there. You remember I referred to the advice that you can give, the HSE advice. They're in that place in the HSE website where MEC is. You know the ones, Sheila, you've looked at them over the years. But Sheila and I teach MEC, and we have done the course ourselves about when it's rolled out, 3 years now, I think. So we're familiar with the tools, and they're all stored in there in that HSE is part of, MEC is part of HSE, and the advice they give is the ones, the HSE advice. So, you know, why not use them? You know, they're there. And is that all right?
Yeah, also they were very anxious that the MEC be involved, be integrated into the training for all health professionals. So
yeah,
medics, nurses, doctors,
everybody.
nurses, dietitians, physiotherapists, pharmacists, the whole works.
Yeah,
are all meant to have done MEC in their training. We certainly do it inside now in DCU. So bear that in mind. If you have a new staff nurse, newly qualified staff nurse, they should have done MEC. So they'll be able to tell you about it as well. But that was the whole idea of it.
Yeah, and it's only brief intervention, Sheila, and it's only, they do call it motivational interviewing, because you're not just talking about had you had a good night's sleep or what the weather was like. You're actually doing something more, a little bit more therapeutic than that, in that you're motivating the person to think about, you know, things that are important for their lives, for their lifespan, which is, you know, the smoking and the physical activity and the, you know, the diet and exercise. So, you know, it's very much a useful tool to have, you know, and also documenting it. I mean, you know, the importance of documenting the conversation that you had. You know, we underestimate that all the time, Sheila. We have these interventions and we never think of writing it down, you know, and I would say to you, you know, every time you do some sort of brief intervention, that you document it, that you had this conversation, because when your patient drops dead from a cardiovascular event or a CVA and their BMI is 40, and they'll say to the nurse, did you not see that coming? Or, and you know, you can say, yeah, every time I met them, I actually documented that I have brought this up, you know. So at least have it to say that you were there doing your health promotion and offering your intervention. I think that will be hugely important. So I hope that meets your needs there. Who was asking me about where to get it. The articles I refer to, I mean, I have the databases at my fingertips, so I can do database searches. Every time somebody asks me a question, I nearly go to the databases for an answer. So I have a great capacity to find articles, and if you're interested in the articles, I like articles that talk about patients and what they want, because the patient's narrative to me is most important now going forward with the way we interact with our clients. So knowing what they say and what they want is hugely important. So I like the ones that do the qualitative interviews, and they're easy to read. And the teams are very something that you can understand, you know, so from that point of view, they're good. The randomized control trials are a little bit harder to read, in that you're looking at p-values, and they may not always make sense to you unless you get to the conclusion and find out what really they found at the end. So there's a lot of reading in between that mightn't help at all. And again, the big document that I refer to from the Lancet, which is the Psychiatric Commission document, who had at least 30 psychiatrists contributing to it, is a very large blueprint. And I would expect that this blueprint will be used for the next 10 years for planning of how we're going to look after the physical health of people with severe mental illness. So that's very important, you know. Other than that, if there's any other questions, or please feel free now while you have us here. I'd love if we could talk directly to you, but unfortunately that doesn't always work out. I also probably should talk about the when you're trying to organise something for your clients, you know, the way we do groups the whole time. And I remember I was saying to you, maybe have a Wednesday afternoon or a certain day of the week where people can drop in. use a model of excellence that you find either in the literature, but also always start out. There's a thing in the literature about behavioural counselling that uses 5 A's. I don't know if you're familiar with this one, Sheila. I think you are. The first A is assess what they know, find out what their knowledge and beliefs are, because then you can pitch it to where they're at, you know, and I know that's very important. And then when you find out where they're at, then you can start your advice. So you can advise, you can give good advice on whatever topic you've chosen to look at. And then maybe you can agree. The next A would be agree some sort of a contract or a short or long-term goal around that advice, whether it be walking or diet or exercise. And then once you've agreed something, you need to assist them. The next A is assist, because people can't follow through themselves. So they may need your assistance to motivate them maybe to go for the walk or do the leisure activity that's enjoyable for them. And the final A then is often forgotten about. And this is where MEC comes in, where you arrange a follow-up. So if your BMI is 40, you need to see a dietitian, or if you're diabetic and your feet are not being cared for, you may be sent to a podiatrist. So always think about how you can arrange follow-up, because we're not able to do everything as mental health nurses. Sometimes we need to incorporate other people in the advice that we're given, and that's how we are always at the end arrange. So just think of it as 5 A's. Assist, assess. Assessment is a big thing. Assessment is huge. So assess what they know, advise then based on that, agree then how you might be able to get there or help them, and then assist them to get there. And then the final A is just arrange whatever follow-up they need, or whatever you think they might need to go back to their GP or go to the nutritional expert or the dietitian or whoever it is. That makes sense.
Yeah, it's the same as what they use in quit smoking. They'd be that's what they use, the 5 A's.
Yeah.
They use with them there as well.
Yeah. It's a good behavioural model used in health promotion, and it's easy to remember 5 A's, you know, and there is articles out there that use these 5 A's that you can easily access, you know, if you're able to get into one of your own databases that you use through the HSE, you will find those articles there on how to do it. And that will give you the basis of running a programme for your clients then.
As I say, you're too busy, and I very much appreciate that. So use the resources we have all the time, and things like Quit are there. We're not good on community dietitians, we don't have enough of them, but you know, even there is the Get Ireland Active physical activity. There's lots of websites there that are. The other thing is you can actually ring the department and you'll get you'll get leaflets sent out, which can be useful, little reminders. They're not complex. And even one of those for a patient, or a client, just to let them have it so they can see them and go over a few possible things to do. Use the resources that are available, because you need support. There's only one of you in that sense. I know you're part of a team, but there's so much else you have to focus on, particularly at the moment. So use what you can to help you, and that's why the screening programs are there. Use them. It's just to get the patient or the client there is the big thing. And we have to be positive about these, and as I say, try to remember them and push them all, and then ask to see how they're getting on.
Absolutely. Yeah. Okay. Does anyone have anything to add to us, or to any comments or anything that you feel we can offer you? Because this is our last session today, and we'd like to think that we could give you, you know, as much as you need, a few tools that might be useful to you in your practice. And we don't know where you're from. You could be working out in a community health centre, you could be in a hostel, you could be in an inpatient unit, you know, and your needs are going to vary according to where you're at and who you're looking after. So, you know, your client base does determine like what kind of interventions you might be offering, you know, and also what type of programs you might be running. But do always bear in mind the importance of screening, and as the article keeps saying, don't just screen, intervene. And I have that drummed into my head over the last few years, that if we're screening, we should be intervening, you know, that we should be offering some sort of interventions, particularly when we know our clients are going to suffer from so many comorbidities and will have, you know, increased mortality than the general population. So I'm just saying this. I'm saying that for 10 years and reading these articles now over 10 or 12 years. And I'm just kind of at the stage now when I feel, you know, we can't just keep repeating this. We have to actually turn it on its head, turn it over, you know, and get rid of this mortality rate and bring it back down to everyone should live the same lifespan, you know, and it is possible for our clients to have as good a lifespan as anybody else in the locality or in their community. So that's our message for today. If you want to contact us, you know, please do so through either our own emails or through the P&A or the RCSI. And it's great. It was a great opportunity for us to work with the RCSI and the P&A, and we're very thrilled to be doing this. We really are. And Sheila, you're very passionate about mental health. For a very general trained nurse with a diabetic background, I have to say you definitely row in, and you have woeful interest in looking after our clients, same as we have. So thank you for that.
Well, the thing is, I just see them as people, like everybody else, and that's the important thing. That's what they are. They're people who need looking after, and they have the same risks as everybody else, and it shouldn't be happening, as far as I'm concerned.
Yeah.
Yeah. I'm just sending the link to Catherine there for MEC for the training. If you could put it up, Catherine, can you, or should I send it to Anya?
No, I'll do it now. I'll send it to Anya. Anya's our technical expert.
Yeah, Anya can put it up.
I just sent it to you while we were talking.
No, that's no problem. I just fling it on now.
I couldn't get it to go into the text box either.
I couldn't get it in the text box. That's why I said it's in.
Yeah, it wouldn't go in.
By the way, I'd also like to wish everyone a happy Christmas who's listening to us, and New Year, because as we say, this is our last session today. So
thank you.
I hope you get some time off and have some kind of a break over the holiday period.
Yeah, it hasn't been an easy year for any nurse out there. So thanks, lads, for sticking in and getting through it.
I've just sent that link there to Anya. Anya, you might pop it up for us. So I think you've answered all the questions going down along, Angela.
More or less, yeah.
And Sheila. So if there's any final questions, it's 3:20, so we're a little bit ahead of schedule, which is great. And again, thank you both for a really very informative session. Thank you. That was very valuable from Teresa Doohan. I am doing health screening as a CMHN, what's that, clinical mental health nurse, and facilitate weekly walking groups with my clients to help them get into a habit of walking. But it is useful to hear some things I'd forgotten to include. That sounds a great initiative, walking groups. I like the sound of that.
Yeah, excellent. Yeah.
Anonymous, sorry now, if I'd known your name, we'll read them, but it's the way you're logged on. Patients are generally well looked after in the hospital setting in terms of physical health monitoring, and this may be because it is highlighted by the Mental Health Commission, but also because you can do things on the spot. Yeah. If patients are attending outpatient services, you have less contact, and they sometimes fall between what is the GP's responsibility and what is primary care and GP. Any advice on this?
Oh, I wish. That's going back to the blueprint, the Lancet document. We are trying to get an integrated circle up and running. It's going to take a while. Look, the UK are probably maybe a bit further advanced than us because they have primary care, but they have nurses working in primary care. And I know in Australia they also have mental health psychiatric nurses working in primary care with GPs. But we're a little bit away from that yet. We don't seem to have a fully integrated communication system going on between our GPs and our psychiatric care providers. But it's something we're going to have to really fix because the fragmented care can't continue. It's not good. It's not good to know.
Can I jump in on that,
please,
Angela, just because it has come up increasingly in the job I do in terms of, I suppose, presentations to the department, and in light of not just COVID, but in general, where this has come up. And one of the messages I keep sending out to those that will listen is that, we have a very good undergraduate program. It has capability, scalability, thanks to Sheila and Angela and people who are basically educating our future and indeed outlining the modules which have been presented here and the MEC and all of those. It shouldn't be the case that if you have an issue in primary care, that you end up at tertiary care to deal with your mental health difficulty. Like, you don't end up, with an orthopedic surgeon with a pain in your leg as the first point of entry. And I think this is a message that policy needs to look at in terms of a stepped approach, as Angela outlines. Yeah. It should be the case, and Angela has said it in Australia and the UK, and I've seen it in Europe as well. Yeah. Mental health nurses are in the network of primary care. They can signpost at that level, not at the far end, as they would see as tertiary services. And this message is a job of work for all of us to try and get it out there that really this is mental health nursing, and indeed aspects such as this, are at every point of care, really, in the trajectory of that. And that is what, instead of this thinking that it's at the far end of care, you know, and that's where we miss out on doing some of this screening when we could have been doing it earlier, you know. It's just a point that I'm at labour to try and share with people from policy level, and there is a lack of understanding about that, I have to say, which is a bit frightening. But I think with messages like Sheila and Angela's and us trying to say that we need to position the profession much earlier in the journey of care for individuals, and whether that's a combination of primary care interventions with a physical ailment or screening or with mental health distress, that's the point it should be at, not at the acute unit in, you know, wherever, albeit that we will use every opportunity and making every intervention count, thanks to Angela, but you know, it is something we need to consider.
I'm glad you're there. I'm glad you're at the table. It's good that you're at the table, Aisling, because health policy is what will determine this. And, you know, our vision for change is well wore out at this stage, and our new policy document certainly needs to include, you know, a whole health policy about the integration of primary and secondary care, because this is what we have at the moment is too fragmented.
Yes.
It's, you know, even the nurses that are listening to this will tell you to try and get through to a GP to find out what physical health drugs their clients are on, or to try and share a blood sample result. It's nearly impossible, you know, so we do need that integration, you know. We certainly will. I'm hoping you'll see it happen maybe in the next 5 or 10 years, I think.
Yeah, I would say I entirely agree, we need it. It is not unique to the mental health services. Can echo it in any of the other services. The idea, we're not good in tertiary care about talking to primary care, we never were. And you say, what can we do? You start by hassling, and you pick up the phone, you leave it on speakerphone and wait for it, and you ring them again and again and again. So you work away with it, because I know how irritating. Because we used to find that with diabetes when I was, we'd never know what the GPs were doing. Now they'd say we never told them, but it was making the context. Now we have improved that now by our community diabetes care specialists, which I want. That's what I was saying. I want them linked into the mental health care team as well when the patient, and it's a case of making those links and connections. We want it done at policy level, but I also think we need to start doing it on the ground ourselves, on a one-to-one. I'm a great believer in little drops, you know, that'll finally wear away that stone, so that if everybody is trying and doing it, and you get to know people as well, and then I can ring up and it's, oh God, it's Aisling or Sonia, and it's you there. And that's what we need to do as well. It's very, very important. So not a perfect solution, but even do what you can yourself. That's and right. we fight on the policy front as well, and it's just getting us there, because, and it's back to this idea, if I can make life better for one patient, we're doing something. And you know yourself, if I can ring up and get the GP and on the phone, not hassle, pour the petal, but you know, if I can get them to be aware of the problems I'm concerned about, or if I can make that link and get started, they're far more likely to come back to me then with when they do make changes like that. And as I say, it's not perfect, but it's a start.
Yeah.
So I don't see any other question. Thank you, everybody, said Tracy. Great session. And they're really, that's absolutely true, Tracy. I couldn't say it any better. So from me, I'm just going to say a happy Christmas to you all. We are working on the programme as we speak, so it could be another little few weeks, but we will aim to have lots of more webinars for obviously the new year. And I hope you get a break, as they said, over Christmas, and stay safe and enjoy some time with your families. So I'm going to hand back to Aisling from the PNA for the final time this year.
Yes, and again, my sentiments are exactly similar to Angela, Sheila's, Anya's, and Catherine's. Once again, it's a little goodbye for now, for a break, respite. It's all about minding each other, minding yourselves, and looking at that whole piece for each other, because it has been a rough, tough year. And you know, going into next year, we need all the energy and the enthusiasm and the motivation to which you bring to these sessions. And without you, we would not be able to continue with the sessions. So it's very much appreciated. Your presence is valued. We know how time is precious to everybody, and whilst it's obviously for the good of those we serve, it's also important to realise that we need to look after one another. So for me, also, this is a goodbye until the new year, where we hope to see Angela, Sheila, and Catherine and Anya, who never appears but's always with us again.
Okay,
Goodbye.
cheers.
Take care.
Thank you.
Bye-bye.
Bye bye, everybody.